EKG. Any signs of ARDC? Going back to last week. ARDC, you have flip T's where? Flip T's anteriorly, and that kind of early epsilon wave, one after your SMB. So no is the answer to that. Normal lab studies, chest x-ray, big kind of flat diaphragm, mild congestion, blunting of the cosphenic angles bilaterally, echo, EF30, kinetic and pure wall. What are you gonna do? MR? When would you do an MR? MR, you're looking for infiltrative, so restrictive. This lady in 2E who's got the big Mickey Mouse atrium that showed up short of breath and then had a glucose of 20 over the weekend, went to the unit. Look at her heart. She's got thick walls, big dilated atrium. You're worried about an infiltrative process. MR. Myocarditis, MR. Does this smell of myocarditis? And not really, right? Akinetic anterior wall, so not diffusely hypokinetic. You're thinking more coronary disease in that setting. So you could argue, well, you can see if she's had an infarct, and so do an MR, but it's not gonna be the first thing we do. You're gonna do a CAC? No, the horse is out of the barn, right? We get CACs for ourselves to, if you're like worried about badness. When you're riding your bike and you get chest pain, then you want to do a CAC, just to see if there's any calcium there or not. Are you gonna stress her? Yeah. This is stress, right? If there was calf on there, would you biopsy, or would you calf or stress?
Stress.
The answer is yes, right?
Yeah.
Either one would
Either
be
one.
fine. So the evaluation for somebody with coronary disease is that you're gonna wanna work up, or for assumed coronary disease, is you're gonna wanna evaluate for coronary disease. So whichever way you do it. So here, yes, C. Number 2, fit for your man, recent diagnosis, systolic heart failure. Imagine, man, have the same bloody thing. 4-month history of exertional dyspnea, no prior medical care, no known medical problems, hypertensive, right, 164 over 96. EF30, moderate LVH. Stress test here, no ischemia, 7 minutes, 10 seconds, peak heart rate 142. So are you happy with that? How old is he? 54. So that's 170, 17 minus that is right around 153 or so. So maybe it's a little bit low in terms of being at maximal stress test, but if a dude goes 7 minutes on a Bruce, you're relatively reassured that that's a good stress, right? Started on lisinopril. You can now walk 6 blocks before experiencing dyspnea. Blood pressure is a little bit better, 150 over 72, heart rate 84, CVP 6, big PMI, no edema, electrolytes getting to normal. Which of the following meds is most appropriate to add? Ha ha! Carvedilol.
Why did they add that first?
Over the lisinopril?
Yeah.
Why did you do
So,
it together?
so I think you can go either way, right? So there's been one study that's looked at it. CBUS 3 took patients and started half of them on a beta blocker, half on an ACE inhibitor. After 3 months, they got the other drug. At 3 months, clinical symptoms and EF, and then at 6 months again. And in both groups, regardless of which one got started first, additive benefit with the addition of the second one.
Okay.
So So it's really kind of dealer's choice. If you have somebody worried about coronary disease or they're real tachycardic, I tend to go with a beta blocker first. If they've got a little bit of blood pressure to work with, I do that too, because I think EF on beta blocker, there's better data for improvement in EF on beta blocker than there is on ACE inhibitors. But at the end of the day, it could be either or, but you wanna get them both. So what about, E?
So well, we'd have to
We have to
clear
hold-
stop list.
Right. Do you wanna do that before you switch to, or add on the carvedilol? He's got blood pressure to work with, right, 150.
Just do drugs.
I think you could, yeah,
His blood pressure is good.
I feel like I would've started those
Do
from
them all
the
at the
start.
same time.
Why can't you do it
Instead of
both?
Carvedilol, or
Yeah.
Entresto.
So the guidelines would say, start in serial fashion. If he was in the hospital, I think it's easier to start both at the same time. But as an outpatient, if you're dealing with this, you might get a little bit nervous about both. First time the guy shows up in clinic, you're nervous, he's nervous. So maybe normally he's running around with a blood pressure of 110 and he's just all jacked up to 150 because parking sucked. And he's seeing a guy who has advanced heart failure on his badge, and they just get nervous about that. So you worry a little bit about it as an outpatient, but yeah, eventually you're gonna wanna get on both. You're looking at me like I'm on drugs.
No, I'm not.
Okay. You guys all agree with this? ACE and then beta? Versus, so would you have him on ACE and beta, or would you switch him to Entresto and have beta at the same time, now that you know that he's got a history of a good blood pressure?
Interesting.
Can he afford the interest?
Any, very good question, as I just saw somebody, $300 a month copay, which seems like it's more expensive than the drug. But, it is what it is. It's like it's a VA, right? They have to pay $7 for every prescription you write. So if you write them for aspirin, you gotta pay $7 for aspirin. So why aspirin? Okay, so yes, add carvedilol. The guidelines really say on ACE and beta and then switch or add, right? So everybody gets ACE and beta, and then you think about the patient. Add Spiro, if they're African American, add Hide-ISO. If they've got blood pressure to work with, add Sac-Val and Entresto. So depending on where they are and who they are, is you go to that next step after ACE and beta is kind of the biggest thing.
Can
I
you
think
start
I'd
on
add carvedilol and then switch them to an ARB. And in 2 weeks, I would stop the ARB and start the Entresto.
Just to
and
make
try
life
to
easier
titrate.
for yourself.
Yeah,
Yeah,
but I think patients have a hard time with that washout.
yeah.
But then that's a lot of medicine there.
So we've been doing a fair amount of, is there ever a time to start an ACE inhibitor now? Or do you start with an ARB?
I feel like it depends on what your end game is.
I mean, obviously, Entresto's better,
Right,
so you wanna get everybody over if possible.
if that's your end game for everybody, then I would say go with ARB, but I think there's people that,
So should that be your end game, right?
from a
Uh,
clinical standpoint,
Yeah, along the lines of puke and lose your hair, if you're gonna have people on the absolute best meds, this is my new thing, right? If you have cancer, you're gonna say, give me whatever it takes, I'll puke, I'll lose my hair, I don't care. If you have heart failure, I don't wanna take another medicine, but most people die more often of heart failure than they do of cancer. So, yeah, so I think that that's legit. I brought that up at a meeting recently, everybody looked at me like I was crazy. Oh no, just stop it for 2 days. I'm like, well, it's so much harder. You're beating on them to take their meds. So it's not around the country, that kind of a feel, but I think it's very legit to just start with an ARB. Even if you're not eventually going to, because otherwise, 2 months down the road, you're gonna be saying, well, about 20% of patients comp with an ACE inhibitor, so now I'm gonna switch to a drug that doesn't test comp. Why didn't you do that in the first place? Case 3, 57-year-old woman, chronic systolic heart failure, admitted progressive dyspnea of 2 weeks duration. After 3 days of aggressive diuretic therapy, she remains dyspneic and right heart cath was performed. Meds are lisinopril, Dig, Spiro, intermittent furosemide. Blood pressure 96 over 74, heart rate 118, respiratory rate 20. Can't see the neck veins, lungs are clear, positive S3, edema to the knees, creatinine 1.7, baseline creatinine 1.2. Here's a right heart cath. You don't get everything, you get RA of 4, wedge of 16, output of 3, index of 2, SVR of 2000. Got that? What do you wanna do?
A,
Is that a joke?
So I hear A,
The wedge was 16, right?
wedge of 16,
But
Our
the
rate's
SVR is
118.
high, and blood pressure's 96.
and the creatinine's up. Should be full.
heart rate's 120,
Yeah,
blood
slow
pressure
heart
is
rate.
low.
Do we have to choose one?
A.
There is no none of the above.
I don't know, if you were in 6A, I'd say there was none of the above.
Definitely not B.
So why not B? So
Because our heart
first,
rate's already high,
heart rate's high,
and
blood pressure's
blood
okay,
pressure's fine.
and renal dopa
It's not, it's
Doesn't
Not a
doesn't
thing.
work. Agreed. If the blood pressure
Jonah's
was
opinionated
80,
about that one.
then you might wanna use dopa, not for perfusion, but to support the blood pressure. And I guess you could say with any of these, which of the following, after transfer to the CCU, which of the following is most appropriate therapy? Okay, so we're saying not dopa. Esmolol, heart rate 120, short-acting drug, will slow her down.
She
Can
might
do
need
it.
that. She might need that heart rate.
She might need that heart rate. Index is 2-1, no, it's not like it's 1-1.
Still in a few minutes, right? Right, keep
Yeah.
volume up.
Yeah, so no. Does she need more diuretics with a RA of 4 and a wedge of 16?
No, and the nitrite will lower her afterload.
Right, and so what's her afterload?
She's got 2,000, her
Right,
SVR's
yeah, so
2,000.
she's all jacked up.
Yeah.
So nitrite, I think, is not available at this hospital, correct?
Right.
It is, I've never used that.
We don't use it.
We just don't use
There's-
it.
We don't use
I
it.
think you can.
It's
get-
like $1,000 a bottle, and there's very few situations where you have to use that where there are not alternatives.
So at other hospitals, you might use Nasiratide.
No,
Oh, that's
you
not
would
available.
not. That one's not even available anymore because you made me check. It is not even available.
You wanna go after that SVR of 2,000. All the others, you have a reason not to do. So the only one that's left is 2,000. And definitely acute vasodilatation, you're worried about lowering your blood pressure. A lot of times, as you lower that SVR, the blood pressure will actually come up. If you're gonna think about nipride or some other IV Hydral or the, whatever the calcium channel blocker is that they use here, nicardipine, any of that, you really need to be in a unit, either an A-line or a really intense nurse that's gonna make sure that the pressure doesn't drop. Cause sometimes the pressure will drop with it, and you don't get that. So many people need that SVR to high. But of these, with those hemos, this is the best answer. Without those hemos, I heard diuresis, and everything else would smell that way, arguing you just can't see the
Yeah.
neck veins being up because we're up here, right? But with that cath, there. And then I think the last question I had, nope. Okay, next one. 56-year-old man, heart failure, admitted to the hospital, 2-week history of increasing exertional dyspnea and fatigue. Diabetic, metformin, lisinopril, carvedilol, furosemide, tolazone, and Dig. Not on a SGLT2 or DP, whatever that is, or GLP-1. None of those, right? Get that out of your head. On exam, blood pressure 88/60, heart rate 95, respiratory rate's 20. 20 is abnormal, right? It's on half of the vital signs, it's abnormal. confused and attentive, JVP is present to the angle of the jaw, S3 crackles, edema to the mid-thigh, extremities modeled, cold to touch. You see it.
We need you guys.
Creatinine 3, baseline 1, sodium 133, no ischemia, big heart, wet. We need to
What was his vital signs again?
88.
Balloon pump or dobutamine?
88, heart rate 95. A or C, I hear whispers.
Renal function is kind of.
Yeah, so you can distinguish between those two based on what? Yes. Renal function, right? I mean, both of them it's low, but yes, I agree with that.
Yeah.
So blood pressure, which one of those two tends to drop your blood pressure more? More than dobutamine, yeah, even if you don't bolus, correct? Yeah, which one don't you wanna get with creatinine of 3? Correct, yeah, so dobutamine there, because milrinone is renally cleared, and over the next 2 days, it's gonna be like you just are escalating from 0.25 to 0.5 to 0.75 to 1.5, and they're gonna drop their pressure eventually, because of that. So you wanna go to balloon? Or you just have no clue and you want a cath?
Your right heart cath and then really figure out what you need to do.
Do you think you have enough data to give you a clue? Or do you need to go to right heart cath?
Sounds like he's not perfusing.
He's not
I mean, he's
perfusing.
cool to the touch, his creatinine's up, like.
He's in shock.
Yeah,
Yeah.
yeah. So he's low output. I think clinically he's low output, right? So if you think about that Lynn Stevenson, what are all the things that say cold versus warm, right? Not making sense up here, cold to the touch, da, 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 worsening renal function, he's there. So, you know all that without a right heart cath. If he doesn't get better, you may wanna go to a right heart cath. And then, so we're really working down to A versus B. Thoughts?
He's sick, start bumping him, see if you can fluff him up a little bit.
Yeah, and if you don't fluff them up, then you use.
Right.
So you would use dobutamine first, and then you would probably, next step, if you didn't get better, right heart cath, and then based on that right heart cath, balloon pump, Impella, ECMO.
Duke.
You can't say, that's after ECMO now, right? ECMO maybe this winter, ECMO's supposed to stay here.
Maintaining? ECMO, maintain on ECMO?
Yes,
Oh,
for pulmonary.
Oh.
Not for cardiac, for pulmonary. So people that are getting CVD, are gonna stay when they come in with the flu essentially. That's the goal. But yeah, so dobutamine here, and that's why. When would you write our cath?
I don't get better.
If you don't get better, when else would you write our cath?
When you can lay down.
When I see you.
If you don't have a clue, right? So,
Isn't that I don't get better? It's anonymous.
Yeah.
so not always, right? So there's the occasional where you're like, this guy, I think he's dry, but I'm not sure.
Mm.
Before I send him out, I wanna get a heart
Okay.
cath. I think he's okay, but I'm not sure. Before I send him out, if his index is 1 versus 2.5, I'm gonna think about him differently. I may still send him out, but it's that kind of I don't know setting. Part of that is if he's crumping, that's an I don't know. If he's not responding, but I think above and beyond that, there might be other times we need to do it. 33-year-old woman, peripartum cardiomyopathy history, delivered a kid 3 years before. Initial EF was 20, and she wants to have another kid. Meds are like lisinopril, carvedilol, no drug allergy.
Take her off the ACE.
You don't even know what the question is.
But she wants to have another baby, so she's even thinking about being pregnant. She should not have the ACE.
136 over 86, heart rate 72, no JVD, no S3, no edema. Do you want to take her off her ACE? Her blood pressure is 140.
We can switch her to something else.
What are you gonna switch her to if she wants to get knocked out?
Amlodipine?
Amlodipine.
Is that safe?
Yeah,
So?
calcium channel blockers are safe.
Is it safe?
What's her EF now?
45.
20?
So,
45 now.
yes, 45, went from 20 to 45. LV size 4.7, so normal, no valvular irritation. What are you gonna tell
Tell them to get a puppy.
Get a puppy.
her? Get a puppy.
D.
Change lisinopril to Valsartan. Still bad in pregnancy?
Yeah.
In vitro fertilization,
No.
New England Journal article,
No idea.
no.
Has there been any clinical, I mean, cause thinking about IVF and all the stuff that you have to like inject into your body and all that stuff, has anybody looked at what that does to folks like who are predisposed to cardiovascular issues like that?
It does not, there's no reports of increased heart failure
Okay,
in the setting of that.
okay.
Stop both ACE and beta, say go for it. Yeah, don't get pregnant, right, that's the answer there. The only time it's safe to get pregnant is if your EF totally recovers back to normal. Even in that setting, about a third of women will develop heart failure with their next pregnancy. That doesn't get better. If their EF is less than normal, about a third of women either die or have a miscarriage with their next pregnancy. So it's a maternal risk above and beyond, a fetal risk. EF not normal, bad. And so you've gotta get them back to normal. There's a little bit of data that if they're back to normal and then you stop their drugs and they're still normal, and then you do a dobutamine echo and they become hyper. So if you got someone with normal EF and they go to 80% with dobutamine, they usually do fine with their next pregnancy. But short of that, don't get pregnant. And it doesn't matter if it's peripartum or viral myocarditis or whatever. EF less than normal, bad for pregnancy.
So if someone like this, say she doesn't listen to you, and you go, well, the ACE inhibitor can cause, fetal demise, and, would you, there's an ethical question, would you keep her on the ACE if she doesn't think,
No, I'd
listen
stop
to, right, change her
Yeah.
to something else?
Keep the beta blocker going. And no data to support this really, but I also get them off carvedilol. And we'll put them on metoprolol or atenolol, because carvedilol, has some alpha, but it's also got this antioxidant BS, who knows what. It's more than just a pure beta blocker. And so to the extent that some of that may screw up with fetal development, I wanna get them on a pure beta blocker that we know is safe. And I don't know if there are reports of carvedilol badness compared to any other beta blocker badness.
No, I think it's all
But I
just,
just do it.
like your thoughts are based on the mechanism and not
Yeah.
actual reports.
Yeah, but I would stop the ACE and just live with that. You can give hydralazine, you can give nitrates. There are other ways that you can treat kind of the afterload part of heart failure. We'll do one more. I got more of these. 77, 5-year history, idiopathic cardiomyopathy, progressive exertional fatigue and dyspnea, stopped carrying groceries in from the car because of the exertional dyspnea, ICD 3 years ago, history of hypertension, lisinopril 40, methotrexate 25, furosemide 40, Spiro 25. 94 over 60, heart rate 70, no fluid. Lights, kidneys normal, sinus PR 0.21, QRS 160, new left bundle, EF 3 months ago 25. What do you want to do?
CRT.
Okay,
What would the primary care doctor do? Stop some of the medicines, cause your blood pressure's too
blood
low.
pressure's too low, yeah. Yeah. But yeah, new left bundle, class 3, this is a perfect indication for CRT. Not sick enough for dobutamine, not sick enough for that, and doesn't have any fluids, you don't need one more. 72-year-old, progressive heart failure, 10-year history, short of breath, climbing one flight of stairs, which is new over the last 3 months, hypertension, lisinopril, carvedilol, furosemide, Spiro. Interestingly enough, they don't want you to put doses in unless dose matters. So that's why you don't see dose on a lot of these. Blood pressure 134/72, heart rate 66, BMI 35. Next veins are flat, no edema, creatinine 1.5. QRS 110, EF 38%, trace MR. Height ISO, losartan, warfarin, CRT.
What were our meds again? That was a long time ago.
You can't
What's her blood
have
pressure?
hydrolysis.
It was like 130.
130.
I agree with Holly.
I think that was Holly, yeah.
What?
Hydrolysis.
High
Height ISO. Right, African American, on good meds, next thing you add is height
And
ISO.
doesn't qualify for the CRT.
Doesn't qualify for CRT because you have 38%, because
And
that's
the
always
QRS
reported
is
out.
2. And the QRS
The
is there.
QRS is 110, right?
Yeah.
Yeah. If they're on an ACE, you don't add an ARB. 15 years ago, that was all the rage. That's a bad thing to do. Warfarin is for AFib, LV thrombus. That's pretty much it. Mechanical heart valves. That's it. TIA strokes. Silver Company had a patient today who had a stroke, TIA. I think that's the reason to put somebody on osmotic coagulation. And whether you do warfarin or NOAC today, who knows? Guidelines don't really comment on it. That's it. Sorry I'm late. I got like 20 more of these.